time, just after 6:30. So hello everybody. It's as I was saying, it's just after 1 o'clock UK time, just after 6:30 in India. So we'll make a start. Dr. Swati is very kindly presenting on a paper that came up in the WhatsApp group, and thought it would be quite a good one to discuss at the Journal Club. Dr. Swati, please, when you're ready, let's take us through the presentation.
Yes, sir. Good evening, everyone. Thank you, sir, for being my moderator and helping me guide through my journal today. We will be looking at the effectiveness of botulinum toxin for chronic tension time headache prophylaxis, a systematic review and meta-analysis. So why tension type headache matters? Because it's one of the most prevalent primary headache disorder, contributing to 26% of the global population annually, and also has a years lived with disability of approximately 7.2%. So when we all know the definition is more than 15 days per month for more than 3 months, and it's more disabling and also causes a hindrance in our work productivity, and also it's a socio-economic burden. That's why it's so important for us to discuss this today. And the direct healthcare cost is almost 64% higher than when compared to the migraine, and it leads to disability, loss of productivity, increased healthcare-related costs, and overall a reduced quality of life. We all know the pathophysiology, so it has both peripheral mechanisms and central mechanisms. The peripheral mechanisms being an abnormal sensitivity of the nociceptor A delta and C fibers, thereby contributing to hyperalgesia, and the mechanoceptor A delta and A beta fibers, which actually lead to allodynia. And so they have also done an EMG where they found that there are sustained muscle contractions localized to these specific pericranial trigger points, also contributing to the pathophysiology of tension type headache. And the central sensitization mechanisms, which actually are indicated for conversion from episodic PTH to a chronic PTH, that includes lowering of pain thresholds and increased central pain sensitization. And these are actually mediated by nitric oxide pathways and sensitization of central nociceptive circuits. And when we did a neuroimaging, there's also associations of reduced gray matter volume in the insula and the anterior cingulate cortex. So the current management challenges that we face, that is the one which has actually led to this paper, is acute treatment for available with analgesics, and we have prophylaxis also like the TCAs and SNRIs, and non-pharmacological therapies are also available. But the limitations here in treatment is the medication overuse headache, the limited efficacy of these drugs, and the adverse effects associated with these medicines. So this botulinum toxin is actually used in several other conditions, which we all know, dystonia, spasticity, and chronic migraine, and it works by the mechanism of cleavage of the SNAR proteins, especially SNAP25, and also mechanism inhibition of acetylcholine release at the enzyme junction. So it also has peripheral and central effects, because of which we are trying to use it in chronic PTH, where peripheral effects are like reduced ion channel insertion in the nociceptive endings, reduced sensitivity of the unmyelinated C fibers, and relaxation of the cervicofacial trigger points. And the central effect by which Botox helps is reduce activation of the wide dynamic range neurons in the dorsal horn and possible inhibition of central sensitization. So the existing evidence that we see for Botox use in chronic PTH, so there are some case reports and small trials which have already been done, and they suggest reduced frequency and intensity of chronic tension type headache when we use Botox. But when they found one systemic review and meta-analysis found actually no clear benefit on the headache frequency. So because of this particular gap in literature, because we have only small studies being done, small trials, and there's only limited data on this headache intensity, and remission rates were not adequately studied. So this came to be the reason why the authors wanted to do a systematic analysis and a meta-analysis on this particular study. So the rationale for the study was previous evidence was conflicting and it was methodologically heterogeneous, and there was a long gap since the last meta-analysis, a decade gap since the last major review, and there was a need for the reassessment of Botox using updated trials and outcomes. So this study aim was to perform a systematic review and meta-analysis of clinical trials and evaluating for Botox A in chronic tension type headache. And they looked into primary outcomes like reduction in the headache intensity and reduction in the headache frequency and the response rate to the treatment. And they also had secondary objectives where they evaluated the demographic moderators, and they looked into the treatment protocol specific factors. And they actually were, the secondary objectives were to identify actually which chronic tension type headache patients actually benefited most from the Botox injections. So they study methods that they followed regarding the registration and reporting. So the study was registered with the Prospero, which is the main registration thing, which as per the PRISMA guidelines, they are supposed to, when we do a systematic meta-analysis, we are supposed to, when all these are there, there's less likeliness of a bias, and it is most accepted by most of the literature analysis and peer reviews. And they have done the reporting of all the data that they have collected, which was completely followed according to the PRISMA guidelines and the Cochrane handbook recommendations. The next, they did a literature search strategy. The databases search were, they included all the databases searching, like the PubMed, the Scopus, the Web of Science, Cochrane, Embase, Ovid, and clinicaltrials.gov. So they have included all the database search. It was not just the PubMed, but they have included all the database in their search for the literature. And their search date was May 1, 2020, and they did not give any language or any publication year restriction. So they just did a complete data search for doing this meta-analysis. So this is how they followed the PRISMA guidelines, where they identified the records through the databases, not only the database which we saw.
Dr. Swati, sorry, I assume this is the same for everyone else. The slides are coming through very, very small on the screen, which has not been too bad, but my sort of or presby myopic eyes are struggling to see. Yeah, but yeah, maybe you could just, thank you.
Yes, sir, I'm really sorry, sir.
Okay.
So they identified all the records. So they identified the records through the database search, and they also identified through other resources also. They have entirely taken all the literature search, and then they have removed all the duplicates. The way they were actually trying to eliminate all the kind of bias that may originate, and then they screened all the abstracts, and they have actually gone through all the full text articles also which were there. They also have done through all the full text articles. And then they have done a meta-regression analysis, and they have decided all the records to be excluded, which were non-human studies, the study samples where they were overlapping groups. So they have also excluded all the records which were not a part of the study. And finally, they have taken 22 studies in this, and the study included qualitative synthesis and meta-regression analysis of 22. There were 11 studies of meta-analysis, and there were 11 studies where they had done a pre and a post-Botox analysis. So totally 22 papers were assessed in this part of the study. So they have completely followed this PRISMA flow guidelines and the chart. And then the study selection. So they pulled all the records and they removed all the duplicates. The titles and abstracts were actually screened by 2 independent reviewers. Full text eligibility assessments were performed, and if there was any disagreements, then that was resolved by a senior adjudicator. And then after they have pulled in all the records, they then started the data extraction. So they had a predefined data extraction sheets, and what outcomes they extracted was the headache intensity, the headache frequency, that is the days per month, the headache duration, which is the hours per day, and the acute medication use, how many patients required the use of acute medications, and then looked into the response rate. So these were the outcomes that were extracted. And to eliminate the risk of bias and the quality of evidence, for eliminate the risk of bias, they used the Cochrane risk of bias 2, and for quality of evidence, it was graded using the grade method. After which a statistical analysis was done. So they did a random effect meta-analysis as per the De Simonian layout. And the software that they used was R meta package. And the comparison was Botox with placebo. Then they looked into the publication bias and the heterogeneity. So for the publication bias, they used the funnel plots and the trim and fill method were used. And they also did Edgar's test, which actually showed no significant publication bias. To rule out for the heterogeneity, that is the effects were consistent across all the studies. To look into that, they used the I2 and the TOS square. And meta-regression was also planned, but they were not able to perform because there were only limited studies and the size of these studies were also small. Hence, meta-regression was not performed because of the limited studies. So they not only looked into the p-value or whether the study was significant or not in certain terms, but they actually defined the clinical significant thresholds. That was one advantage of the study. So they called it as MCID, which was minimal clinically important difference, the MCID that was already predefined. So they already predefined this, that they were going to look into how the headache intensity is reduced. So if the headache intensity had a standardized difference of more than or equal to 0.5, then it was a significant one. And for the headache frequency, they defined the minimally clinically important difference to be more than 1 day per month reduction. For acute medication use, it was more than or equal to 1 day per month reduction. And for the headache duration reduction of more than or equal to 2 hours per day. So this was their criteria that they set for finding out whether they were clinically significant thresholds. So then the results. So the study selection actually was, which I showed in the Prisma flow chart, that included actually 11 interventional studies and 11 randomized control trials. And the total participants were 652 chronic tension type headache patients exposed to Botox. And so this is in again short, where the randomized control trials we can see on the left side. They were total studies of 11 papers were used, and the other 11 papers they were single arm pre and post intervention studies. So total of 22 studies were done, and we have the sample size, the mean age, and females, Botox dose, and follow-up. So all these were the statistics that were taken in this analysis and for further meta-regression analysis. So the quality of evidence, which we said was graded with grade ratings. So they looked into the whether it was moderate quality, low quality, and the risk of bias was also seen. I'm just skipping this slide. So the first primary outcome that they looked into was headache intensity. So Botox significantly reduced standardized headache intensity when compared with the control. So we can see the effect size as delta of minus 0.502 standard deviation. So we already described the minimally clinical difference. So MCID for primary outcome for headache intensity should be more than or equal to 0.05. So that was actually achieved here. It was 0.50, and the confidence interval also levels are less than 1. So this is actually a significant study, and the p-value is also less than 0.05, which implicated that the headache intensity effect was actually significant. So the improvement actually exceeded the predefined MCID, which was 0.5 for headache intensity, which they are already predefined. And the effect robust on leave one out sensitivity analysis was also seen. So when we try to remove each paper one by one and still look into the MCID values, they were still significant, which means that one particular study alone didn't contribute to the effectiveness. So overall, all the studies were equally contributory. So the next slide, we can see the same, the forest plot, which we can see here. So on the left-hand side, we can see all the studies that were taken here. And we can see the standard deviations. So the forest plot, we can see that the pooled MCID, the standard deviation was actually less than 0, which actually favors that Botox had a better effect. We can see the MCID value, it was pooled was 0.5, which was predefined value, and this value actually was exceeded in this particular analysis. So we're going to look into the second.
Sorry, Dr. Swati, just go back to that previous slide, if you would.
Yes, sir.
So the effect size is not the change is not in standard deviations, is it? What's the unit of headache intensity?
Sorry, sir. What is the? Sorry, sir.
What's the unit in terms of the what? Because standard deviation
is the standard deviation. So that is how they have defined in that MCID, minimal clinically important difference for headache intensity is the standardized difference of more than or equal to 0.5.
Depending on, so that's irrespective of how they've defined headache intensity in their trials.
Okay.
Yeah. Because normally,
Yes,
how would you, I mean, normally, how would you normally, what units would you,
yeah,
I mean, you normally
they
use a
had,
visual analog scale,
yeah.
headache intensity of 0 to 10. Okay. So just to make the point that obviously, unlike the other outcome measures here, which have got specific units, days, hours, and so on, this is irrespective of the way that people have defined headache intensity, isn't it? It's just a deviation from the does it deviate by more than half a standard deviation? And they're assuming that if it deviates by that much, then it must be clinically significant. Yeah.
Yes, sir. Yes, sir. I think they
Okay.
had used multiple scales for the intensities, sir. I think
Yeah.
I will, but that will be coming the end of the slide. But I think they were West Haven scale, and there was one more scale. But I think that was the difference. I think that is the way the quality, the bias, probably the
Right.
study had some limitations.
Yeah. It's difficult, isn't it? Because I think most clinical trials use headache frequency as the primary and the second and for a lot of their secondary outcomes, because I think people have much more difficulty in getting on top of headache intensity, because obviously some trials and studies just use simple, four, a scale of no pain, mild, moderate, severe. Obviously, a lot of studies would use a kind of 0 to 10 scale. But this is a way, I think, of trying to put that all together. Anyway, sorry to interrupt. Do carry on.
Yes, sir. So the next outcome that we are going to look into is the headache frequency. So we had defined the headache frequency of more than or equal to 1 day per month as the MCID. So here we saw the effect size of minus 2.83 days per month. So it was more than 1 day, it was 2 days per month. So the headache frequency reduction actually exceeded here also the MCID of more than or equal to 1 day per month. And the effect also remained robust across the sensitive analysis. So we can see the forest plot here. There were certain studies where actually the confidence intervals crossed more than 0. It crossed 0 as well. However, when they took the pooled mean difference, it was actually below 0, contributing to favoring more of Botox. And the MCID, which you can see here, is minus 2.83. Where they had defined as more than 1 day per month to be a significant reduction. So this also had a significant reduction as per their meta-analysis. So yes, sir. Should I stop here for the headache frequency, sir?
No, that's fine. You can carry on.
Yes, sir. Thank you, sir. And the next they did the exploratory pre and post meta-analysis. So there were 11 studies where we saw they were pre and post meta-analysis was done, pre and post the procedure, how it was. So those studies were separate exploratory meta-analysis was performed, and they included control trials with single arm pre and post studies. And here they found the pooled pre-post reduction in the headache intensity of minus 1.38 standard deviation. So this was in the confidence interval of less than 0 and less than 1. And there again, we had the headache intensity being measured with MCID of more than or equal to 0.5 standard deviation. So that also was significant for them. And then they did the moderator analysis where they looked into the significant moderator factors, the factors that will actually contribute to reduction in headache by using Botox. So in that, they had a significant moderator of increasing age. So they saw increasing age was associated with a greater Botox benefit, and that p-value for that was very significant actually. Other moderators were not actually statistically significant. The next secondary outcome was headache duration per day. So more than 2 hours per day of headache reduction is what the MCID that they had predefined. So headache duration was a very decrease in the headache duration was a less reliable outcome here. So there were only actually 3 control trials which actually reported about the outcome. And when they saw the reduced headache duration, they saw the difference was 0.97 hours per day. In contrast to the MCID, where we had suggested of more than 2 hours per day to be the clinically important difference. But this particular value, p-value was significant. P-value was less than 0.05, indicates that this reduction in headache duration is significant, though it did not meet the MCID criteria of more than 2 hours per day. So this is the forest plot for the same study. There were only 3 studies which actually contributed to the outcome, and it was the pooled analysis mean difference was less than 0, favoring Botox. However, the p-value was significant. Though the p-value was significant of less than 0.05, the MCID was not achieved in this particular outcome of headache duration per day. The next secondary outcome was acute medication use. So there were only 4 RCTs which actually reported adequate acute medication intake, and they found that Botox actually reduced acute medication use by minus 2.2 days per month. And that was also statistically significant. The p-values was less than 0.05. And what predefined MCID was set was more than 1 day per month was the predefined MCID that was given. So they actually, this particular outcome actually exceeded the predefined MCID because there was 2.2 days per month reduction in the acute medication use. The same thing we can see here in the forest plot, where the pooled analysis is actually below 0 on the left side, favoring Botox, and minus 2.2 days reduction was seen. So this also was a significant one with MCID also, with also approving the MCID criteria. And then the exploratory meta-analysis for pre and post frequency. So we totally had a pre-post frequency 12 intervention arms, and here we saw that the intensity again, the Botox was significantly reduced the headache frequency actually by 4 days per month, and we had actually given as more than 1 day per 2 days per month reduction as a minimally important predefined criteria. So here 4 was also very significant. However, this particular thing had a high heterogeneity of 98%. So heterogeneity means it was not over the studies, it varied. So though it improved, this will be of, when you grade this evidence, it will be of low or a moderate grading of this particular analysis. And then we looked into the response rates, the relative benefit. So the random effect meta-analysis of response rate was done, and they found that Botox was associated with 79% higher likelihood of response when compared to the controls, and the relative risk was 1.79, and the p-value was also less than 0.5. So which indicated that benefit was consistent across the response definitions. It's the same forest plot chart for the same, sir. I'm skipping this. And then we looked into the response rates, absolute benefit, and the number needed to treat. So we found that the absolute response rate improvement was there of 0.12, and the p-value was also significant here. And we actually needed 8 patients to be treated with Botox for seeing improvement in 1 patient. So number needed to treat was also quite less. So treating 8 TTH patients with Botox showed 1 additional responder. The same study. And then the sensitivity and the bias analysis was done, where they did the leave one out sensitivity analysis, where they will when they removed each study 1 by 1, and then also when they looked into the values, they were still significant, meaning that just one particular study is not contributing to the entire effects. And the publication bias was also done by Eggers and Peters test, which was also not significant. And for bias analysis, they also did trim and fill analysis, which did not alter any of the conclusions that they had achieved. So the overall summary of the results was strongest evidence was there for headache frequency reduction and acute medication use. Modest evidence was there for headache intensity reduction, and there was a weak evidence for reduced headache duration per day. And then they did the heterogeneity and the meta regression. And the significant between study heterogeneity, we saw the I-squared was 84%, and this was the p-value was also significant for the heterogeneity testing. And meta-regression was actually not possible because of the limited number of studies, but it was possible to do it just for Botox dose. And when they did meta-regression for Botox dose, they found it was a significant negative moderating effect with a significant p-value. And then the quality of life outcomes was measured, but this was also not very great because there were only 2 control trials which reported the quality of life data, and they used different instruments for doing it: the Human Development Index and the West Haven Yale Multidimensional Pain Inventory. Meta-analysis was not performed because of incompatible scales here and lack of validation for cross-comparison. So the key findings are this is the first comprehensive meta-analysis of Botox in chronic tension type headache using multiple response indicators, and there were statistically and clinically significant improvements in headache frequency, headache intensity, and acute medication use. The mean daily headache duration reduced of less than of approximately 1 hour. It was statistically significant, however clinically modest, and overall response rate was 79% with Botox A versus the control. It's the same thing. So why this meta-analysis was different from the earlier ones? So the earlier meta-analysis compared the post-intervention headache frequencies between the intervention versus control, while the current they use pre and post-intervention differences, and they also included other additional eligibility study. And they also used update trial data, and they focused more on the clinically meaningful outcomes, the MCID, not just the statistical significance of p-values. And they actually did separately the randomized control trials and exploratory pre and post analysis. So they were separately done, and they also incorporated grade-based evidence appraisal. So the strength of the study was it was Prospero registered, which is very important when we have peer reviews and we are going to put in publications, especially for meta-analysis. The Prisma, and they use Prisma complaint methodology. It was conservative random effects model. There were explicit definitions for the MCIDs. There was robust sensitivity analysis done, and it addresses both the statistical and the clinical significance. However, there is also limitations because there were only limited number of high-quality randomized control trials. There was heterogeneity difference in the studies that were mostly related to the Botox A dose, the injection sites, and the treatment protocols used. Low-grade certainty were there for certain outcomes. Meta-regression was limited because of the small study numbers. There was lack of standardized quality of life reporting here, and there were short follow-up duration. So that were the limitations of the study. So the clinical implications, we can consider for refractory TTH, but we have to select our case as well. Particularly relevant when migraine-like features coexist and peripheral sensitization is suspected, and there is a need for large RCTs and repeated dosing and longer follow-ups. To conclude with current mechanistic and clinical evidence such as potential efficacy of Botox in TTH prophylaxis, the meta-analysis shows statistically and clinical significant reductions, and we graded these reductions also, which were very good in some and modest in some and very weak in some. So the treatment response also appears to decline with increasing age and higher Botox doses. Evidence of quality still remains low to moderate, and we require adequately powered high-quality RCTs to identify who are going to respond well and optimize the dosing strategy and the protocols for Botox. So this one best practice in meta-analysis, and what do we consider by best practice? So when we have a predefined protocols, which is Prisma compliant, when we do a comprehensive research literature search, just not the PubMed, but all the other literature databases also search, when we have a very clear inclusion and exclusion criteria, assessment of the study quality, assessment of the risk of bias, using an appropriate statistical model like random effects when heterogeneity exists, exploration of these heterogeneity by means of meta-regression, sensitivity analysis, and cautious interpretation without overclaiming things. So this is what we consider as best practice. So did the authors follow best practice here? From what I went through, sir, and what I understood from the study, sir, yes, largely they have gone through the Prisma guided systematic review and meta-analysis. They have taken a broad search strategy with explicit eligibility criteria. They have used random effects models. They have given appropriate heterogeneities check. the risk of bias was checked. They have conducted meta-regression over their very limited numbers. They have performed the sensitivity analysis and there was a transparent reporting of whatever limitations they had. But yes, there are some limitations. There was only small number of eligible studies, low to moderate quality of included trials. There was considerably clinical and methodological heterogeneity, and there was limited quality of live data. With meta-regression was constrained because of sparse data, sir. So with this, sir, I conclude, sir.
Very good. Well done. Well done for getting through those slides in half an hour. That was a very good
Yes.
effort. You need to just
Yes.
have a glass of water and just take a beat. No, that was a really good presentation, and thank you very much for doing that.
Thank you,
Um,
sir. Thank you, sir.
can I ask? We've got about I don't know. There's probably about 8 or 10 people on the call. Is there anybody on the call that currently would use Botox for patients with chronic tension type headaches? I mean, you can put your hand up or you can shout out. Is there anybody that would do that?
मेरे दोस्त नहीं हो, मेरे नौकर हो, मैं तुम्हें
नहीं, ये मेरा हेड का फेलोशिप चल रहा है जिसका मैं एक भी लेक्चर अटेंड नहीं कर रही हूँ।
And is there anybody that, having listened to that presentation, would now consider using Botox for somebody with chronic tension type headache when they hadn't done before? Okay. Okay, well, look, let's just have a little bit, just for 50, for a few minutes. Let's just consider that piece of work. I think it's really important. It's very, the first and most important thing to say is that meta-analysis is not just a systematic review, and doing meta-analysis properly is actually, quite a complex thing to do. And one of the things that is important when you're doing meta-analysis properly is to actually follow the guidelines of how it should be done properly. And obviously, this has all come out of work that was originally done by the Cochrane team, who developed the sort of the standardized techniques for doing these types of analysis. And although the numbers are very small here, I mean, this is where meta-analysis potentially comes into its own, because if you do it properly, it does allow you to draw robust statistical and hopefully clinical lessons from data that may not be the best quality that we have. One of the most important things about doing meta-analysis is actually trying to include all the possible data that you can. And one of the sort of crucial things is to try, when you're doing meta-analysis, just to try, if you can, to ensure that you identify and, if possible, include trials that never made it to publication. And that's obviously why they go to sites like clinicaltrials.gov, because there remains a propensity for people not to publish negative trials. I mean, it's less of an issue now than I think it probably was, 10, 15, 20 years ago. But because obviously, I mean, there's obviously an explanation for that an awful lot of these trials are sponsored by pharmaceutical companies, and they, if their trial comes back negative, they don't want to publish it, because that may put the kibosh on anybody kind of actually thinking about using their product at all. So one of the innovations when people started to do meta-analyses was for people to actually actively seek out unpublished trials, number one. And number two, if possible, to try and go to the original data sets if they were available, rather than just relying on what was ultimately published and put out there in the public domain. And I think for a study like this, I don't think that I couldn't see any evidence in the paper that they had systematically tried to identify unpublished studies. and they hadn't gone back to the original data, which obviously is potentially is a shame because you may get slightly more granular data, particularly on things like headache intensity. Again, if you're interested in that, and that wasn't an original outcome in some of the original trials. So I think, could they have done a little bit more with that? It's possible. But in other respects, as you say, Dr. Swati, they do seem to have, actually, made a very good attempt to identify, all the relevant, published data on the subject. At the end, they claimed that, that there were two or three things that they claimed at the end that made this study, worth having done, given the fact that there is a previous meta-analysis that had been done, about 15 years ago. One of the things they said was that they were doing a reassessment with updated trials and outcomes. Did they actually do an assessment with updated trials, Dr. Swati?
I honestly don't know, sir.
Okay, well, so I don't know for certain, but what I did notice is that all the trials that were, or certainly all the randomized controlled trials that were included in their analysis were all published before 2008, which is when the preempt trials were published. So they were all done, and I couldn't see anything that was included, certainly in the randomized control studies, more recently than that, which is interesting, isn't it? Because you would have thought perhaps, given ultimately the success of preempt, that might have induced people to go back and look at that chronic tension type headache population again. Now, of course, in the original kind of 10-year lead up to preempt, the trials that were done ahead of preempt, a lot of those were done with patients with undifferentiated chronic headaches. They were done with patients with chronic daily headache. So part of the process that eventually got to preempt was actually the company pulling out the patients with chronic migraine, as they came to define it, because they did seem to do better than patients with other forms of chronic daily headache. And it's interesting, isn't it, that in this study, I mean, it's a meta-analysis, but the overall improvement in terms of headache frequency is 2.8 days per month, or if you do a sort of pre and post analysis, it's about 4 days a month. And of course, what's the improvement in preempt, at 3 months in the chronic migraine patients? It's 9 days a month. So the treatment effect in preempt seems to be about 2 to 3 times greater than what's seen in chronic tension type headache, according to this meta-analysis. So that's quite interesting, isn't it? That there is a clear effect that comes out of this, and there's consistency across the outcome measures that they've chosen here, the clinical outcome measures that they've chosen, and we'll come back to those in a minute. There is consistency, which again, is suggestive of a genuine effect, but it may indicate that the overall level of the effect, in this patient population may not be expected to be as high as in the migraine population. So that's interesting. So I think they say, we've used updated trials, but actually, I'm not sure that there are many updated, there's many post-preempt trials that have actually made their way into their analysis. The second thing that they say, which I think is interesting, is they say, look, we're looking at clinically significant, outcomes here. So it's not enough to say that something is statistically significant if it's not clinically significant. You can have a statistically significant result of 0, of no effect at all. That can be statistically significant, often is, in a negative or non-inferiority study, but that doesn't mean that there's a clinical difference. So what do we think of these minimal clinical differences in the trials? So let's start off with headache days. So that the minimal clinically significant difference in headache days was how many?
2, sir.
2. Okay. what do we think about that as a, I mean, just generally, what do we think about that as a minimal clinically significant difference in headache days in this population? I mean, do you think that's a reasonable number, or do you think it's, is that, would you be looking for a higher number than that in clinically significant?
It depends on the number of days a patient actually has headache in a month. So
okay, but they're chronic. They're chronic tension type headaches. So by definition, it's 15 or more, isn't it?
More than 2 days. Yeah. So 2 is just, I think, still a very low number.
It's a pretty small difference, isn't it? Now, obviously, you and I and everybody on this call will have looked after patients who would take 2 less days a month, and they would be happy to have 2 less days a month, or 2 fewer days a month, I should say, 2 fewer days a month. But it's a fairly small difference. But they have presumably predefined that, and they have met that. I mean, obviously, with the intensity, it's different because it's a kind of standard deviation measure. Half a standard deviation is that clinically significant. It's a bit more difficult to kind of say. Clearly, again, the medication use days, again, similar kind of figures. So I think, they've given themselves a relatively low bar, and they have met it. And actually, to be fair to them, giving themselves any form of kind of bar from a clinical point of view is a sensible thing to do, and it adds value to the study. And obviously, then you've got an NNT of 8, which again is it's quite a that's an interesting number, isn't it? You've got to treat 8 people with Botox to make one significantly better, which is a fairly for an intervention of this nature, it's a reasonably high number. I can't remember what the NNT for preempt and chronic migraine is, but it will be lower than that, obviously, because the effect size is higher. So again, I mean, having read this meta-analysis, will this change your practice, Dr. Swati?
There were certain things which were actually statistically significant. There were some which had a heterogeneity, a very huge heterogeneity, making it actually a low to moderate reasonable outcomes. So I will choose my patients. Definitely, I will consider this paper, and I will choose the patients on whom I would want to go for Botox injections, maybe who are refractory to any form of treatment or who have a coexisting migraine. So I think a prudent selection of patients should be the first thing to look forward to.
Yeah, I mean, I think that's a pretty reasonable response to the paper. I mean, obviously, patients with chronic tension type headache who also have episodic migraine, there is a school of thought that says that the biology of what's going on is all migraine anyway. But that's a discussion maybe for another time. But I think yes. I mean, I personally, I would. And I have, on occasions, tried Botox for people with persistent featureless headaches, if you want to put it that way. And some of those patients have derived some benefit from it. And I think this is one of these areas where everybody when they do a paper like this says, oh, we should have more research. But it would be, I think this is an area where it would be. It would be very useful actually to have someone go back now and do, a properly powered, clinical trial, maybe, using the Botox protocol in a well-defined and diagnosed population of people with chronic tension type headache, and actually try and derive some class 1 evidence for the effect or otherwise. Because, as you mentioned in the beginning, in the introduction, we actually have relatively few, options for chronic tension type headache. And although, it's probably less common than chronic migraine in most of the populations that, as headache experts you see, it's still nonetheless actually, quite a common presentation, and actually a very debilitating one. People don't have to have hugely severe headaches to be, functionally disabled by them. Having headaches day in, day out without remission relentlessly is incredibly debilitating and wearing for people. And so any options that we might have. And I think also, trials that use, patient-derived outcome measures, even things like HIT6 or MIDAS, would be useful, because I think, again, coming back to this minimal clinically significant difference, I think there's a much greater consensus on what would be regarded, for example, in HIT6, there's a pretty clear consensus that a change of 5 on a HIT6 is, a clinically significant improvement. Whereas I think there's a little bit less consensus just on headache days or migraine days. So again, if you had that data, that would be quite useful. But again, that comes back to the fact that most of the studies that they've actually ended up including in this are, studies that are now 20 years old or more, and are not being done in quite the way that somebody would do a study now. Does anybody on the call have any questions or comments that they'd like to make? Okay. Well, look, I mean, I guess my last comment really is just to go back to the slides right at the end about, how you do a good meta-analysis and whether they actually did them. And I think it's really important when you're looking at meta-analyses. You can go on if you Google Cochrane and meta-analysis, you'll get quite a lot of good stuff on how you do a meta-analysis, and it's worth looking at that and just revising that, because you see meta-analysis, it's an interesting thing. Lots of people who do PhDs or MDs in any topic in medicine, their first chapter will be usually a systemic review, and they may try and do a meta-analysis, and then they may try and get that published after they've finished it. And there's quite a lot of poor quality meta-analyses out there, but good quality meta-analyses are very interesting and can provide quite a lot of useful data. And I think this is generally a very good quality study. So I think if you see meta-analysis in the literature, just download one of those checklists from the Cochrane site and just go through it and go, have they used, have they done this according to, best practice, and a really good thing to look for in a meta-analysis is, have they tried to identify unpublished studies? Because if they've gone to the effort of properly trying to do that, then they've almost certainly done everything else properly. So if they don't mention having done that, then you have to go, okay, are they really serious about this as a study? But if they have done, then that suggests, just a single point to look out for. It suggests that they probably knew what they were doing and have done it properly. Okay, well, look, again, many thanks indeed to Dr. Swati for an excellent presentation. It's a really interesting. It's an interesting topic, and very well done. So thank you very much indeed for your time and effort, and the presentation, which was first rate.
Yes, sir. Thank you, sir. Thank you so much.
That's okay. So just to remind everybody that the next Journal Club is scheduled for 4 weeks today, on Monday the 2nd of March at the same time. We're looking for someone to put their hand up and volunteer to present. If you want to present but you don't know what to present, then obviously please get in touch with the team and we can give you some options to consider. But otherwise, thank you very much, everybody, for attending. For those of you who are watching this online, I hope you enjoyed it and found it interesting. And we will see you again next month.
Thank you, sir.
Thank you
so much.
Cheers, guys. Thank you very much indeed. Have a good evening.
Thank you, sir. Good day too, sir.
Cheers.